Hello, Clinic Review family. Dr. Sharon with Clinic Reviews. Today I'm going to continue talking about hemodynamics, but we're going to do all SATA questions. This is part of physiologic adaptation. So let's go ahead and get started. Hello, my friends. It's Dr. Sharon with Clinic Reviews, the home of the very best Nclex review in the entire universe, in my opinion. You know that Clinic Reviews is an organization that helps you prepare for Nclex, which is primarily what this channel does. It does help you with other standardized tests like ATI and HESI and any others that you might be taking. It just helps with Nclex style questions. It helps you to learn how to think and how to clinically reason and to use common sense to think through the questions. That's the purpose of these videos. I am not teaching you content, although I do occasionally teach a little bit of content. The content that will help you for this week is from the previous video I did. It's going to be also called hemodynamic monitoring. This one's going to be called hemodynamic monitoring SATA. So the other kind of the twin video that goes along with this is just a straight up hemodynamic monitoring one where I teach about managing blood pressure. Remember, hemodynamics is all about managing blood pressure. That's what that word really means. So hemodynamics, managing hemodynamics is part of physiologic adaptation, and it's one of the most important things that we do as nurses. So sorry, I got off track. You can go to clinicreviews.com, sign up for our 21 plus hour Nclex prep. It's online on demand. It's the same as the 3-day review that Mark does in person. And we also have a streaming service. A lot of the videos that I've taken off of YouTube are still on our streaming service. In fact, all the videos I've taken off YouTube are on our streaming service. And let's see what else. Oh, you can meet me in person over Zoom if you want to do our small group next gen tutoring that I do. Okay, let's go ahead and get started here. So these are all SATA questions as they relate to hemodynamics. A client is admitted with septic shock, which interventions should be included in the management. So shock is a synonym for impaired tissue perfusion related to low blood pressure. Impaired tissue perfusion related to low blood pressure. So what you have to do is pay attention to what type of shock it is. All shocks have low blood pressure, but the type of shock tells you why they have low blood pressure. With septic shock, it's a result of infection that has gone system-wide and caused vasodilation. Remember, blood pressure equals stroke volume times heart rate times systemic vascular resistance. Vascular resistance has to do with vasodilation and constriction. So as the vessels dilate, blood pressure goes down, and that's what happens in septic shocks. We have vasodilation. Which intervention should be included in the management? Obtain lactate levels, start broad spectrum antibiotics, apply warm compresses to the extremities, administer IV crystalloid fluids, elevate the head of the bed to 90 degrees, monitor central venous pressure. Okay, so let's talk about this. So we have an infection and we have low blood pressure. Now, lactate levels are specific to septic shock. They give an indication of how much anaerobic metabolism is going on because we have poor oxygenation and tissue perfusion. So it looks at anaerobic metabolism. So lactate levels go down as we get more oxygen to the tissue. So we do obtain lactate levels. Broad spectrum antibiotics are yes, because it's septic, it's an infection. Apply warm compresses. Well, if we apply warm compresses, that's going to vasodilate. Y'all, we already have a problem with vasodilation. Septic shock is massive vasodilation, so we don't want to apply warm compresses. Administer IV crystalloid fluids. Remember, crystalloids are crystal clear, and it's the first line thing that we always do to try to increase blood pressure. So blood pressure equals stroke volume times heart rate times vascular resistance. Well, stroke volume goes up if we increase volume. So if stroke volume goes up, blood pressure goes up. So administering crystalloids is a very high priority. Elevate the head of the bed to 90 degrees. Well, we already have poor circulation, and gravity alone, if you sit them up, gravity alone is going to pull some blood from their brain, which we don't want to do because we're not vasoconstricting. So that does not seem like a good idea. Just common sense and clinical reasoning says don't sit them up. Monitor central venous pressure. So central venous pressure goes up when there's more volume, and it goes down when there's less volume. But septic shock is not a volume issue. It's a dilation problem. So do you think pressure goes up when there's dilation, or do you think pressure goes down when there's dilation? Remember, septic shock is dilation. So do you think the pressure goes up or down? Well, it goes down, obviously, right? So if we're monitoring central venous pressure, it's a very direct way to monitor blood pressure, right? Because shock is impaired tissue perfusion related to low blood pressure, secondary to dilation. So if we monitor central venous pressure, that's going to give us a pretty good idea of how we're managing this problem. So those are the correct answers. A client with myocardial infarction is developing cardiogenic shock, so another type of low blood pressure, this time related to a failing heart. So impaired cardiac output. There's a problem with cardiac output, with not volume and not dilation. It's the cardiac output is down because of a failing heart. Which order should the nurse anticipate? Intra-aortic balloon pump insertion, IV nitroprusside infusion, dobutamine infusion, strict intake and output, immediate hemodialysis, continuous ECG monitoring. Okay, so we have low blood pressure. However, the problem with cardiogenic shock is we have low blood pressure related to a failing heart, which results in the appearance of fluid volume overload. So when the heart's failing, it backs up to the lungs, it backs up to they get JVD, they get peripheral edema. So giving IV fluids is not the treatment of choice for this one type of hypotension. So we're not going to give crystalloids, and it's not even there. And that's why it's not there. Now, an intra-aortic balloon pump is something we do in the ICU. I have not worked with one, but I know enough about them. It has to do with putting a balloon in the aorta. And I don't know exactly the time frame of when it deflates, but it deflates at the right time so that the heart has to use less energy to eject the blood from the heart. Okay, that's what an intra-aortic balloon pump does. So you have a balloon in the aorta, and it inflates and deflates in a pattern along with the pumping beating of the heart, which allows blood to exit the heart easier. So we have a failing heart. And so just knowing what I do about an intra-aortic balloon pump tells me that if we have a failing heart causing poor tissue perfusion, an intra-aortic balloon pump would help. So I like that answer. Nitroprusside. Well, nitroglycerin, even if you don't know what nitroprusside is, nitroglycerin we give with chest pain, right? With angina. And what does nitroglycerin do secondary to treating angina? It lowers blood pressure. So nitroprusside lowers blood pressure. We give IV nitroprusside to treat hypertensive emergency. So we give nitroprusside for high blood pressure. This person has low blood pressure, so don't give them nitroprusside, y'all. Okay, dobutamine. In the previous partner video to this, where I talked about hemodynamics, I talked about how to increase stroke volume. And I said you give inotropic agents. Inotropy is the strength of contraction. So we give inotropic agents, and dobutamine is an inotropic agent, increases strength of contraction, their heart failure. So dobutamine makes sense. Strict intake and output. Yes, because if we're perfusing our kidneys, if the heart is getting enough blood out to perfuse the kidneys, urine output is going to go up. It's going to give us some indication of the health of the heart. Immediate hemodialysis. So dialysis takes fluid off. We may want to do that, but what order should the nurse anticipate? That's not usually how we treat fluid volume overload. That's just not usually how we do it. It's just not a common treatment. So unless, I want to answer questions based on my knowledge, not my ignorance. And even though I know hemodialysis can take fluid off, my knowledge says that's not a common treatment for fluid volume overload, unless it's renal failure. And they didn't tell us anything about renal failure. Continuous ECG monitoring, well, obviously, that just makes sense. Okay, so the correct answers are A, C, D, and F. Now, that's a difficult question, y'all. These are not easy questions. If you haven't watched the hemodynamics previous video, I'll go ahead and partner it up with this video so that you can click on it if you want to at the end, if you haven't watched it. But it is, I think it would be helpful in better understanding blood pressure. And I've also done specific videos on the different types of shock. So if you want to go and watch those that would help you as well. When planning care for a client on warfarin, which dietary and medication teachings are appropriate? Warfarin, dietary and medication. So warfarin, eat consistent amounts of leafy greens, avoid alcohol binges, take aspirin for headaches as needed, use a soft toothbrush to prevent gum bleeding, expect dark, tarry stools while taking warfarin, increase intake of foods high in vitamin K. All right, so we are doing hemodynamics, but we're also doing Sata questions. So remember, the rule when doing Sata questions is you read the question, you read all the answers, and then you read the question again to make sure you didn't miss anything. Which warfarin, dietary and medication teachings are appropriate? So we're looking for good things to do, okay? Good things when they're on warfarin. Eat consistent amounts of leafy greens. That is what we're teaching people. Leafy greens have vitamin K. Vitamin K is the antidote to warfarin. So we used to say don't eat it at all. Now we say eat a consistent amount. So eating a consistent amount of leafy greens and organ meats also are high in vitamin K. So that's a good option. Avoid alcohol binges. Well, it's always good to avoid alcohol binges, y'all. That's just a good Nclex answer. Like stop smoking. Yep, good answer. Picking it. Okay. Avoid alcohol binges. Take aspirin for headaches as needed. Well, aspirin is an antiplatelet, which will increase bleeding. So I don't like that option because they're already taking warfarin and then aspirin is going to increase bleeding more. And I don't want to do that. Use a soft toothbrush to prevent gum bleeding. Well, that is a good option. They will be prone to gum bleeding. And so, yes, I want to do that. Expect dark tarry stools while taking warfarin. Y'all, no, that's like saying expect GI bleeding while you're taking warfarin. I don't want you to expect GI bleeding. I want you to call if you have dark tarry stools. You're not supposed to have a GI bleed when you're on warfarin. Increase intake of foods high in vitamin K. That's the opposite of answer A. A and F are opposite answers. They cannot both be right. And so I know A is right, so I can't pick F. So A, B, and D. A client with hypovolemic shock, so another type of shock, which is impaired tissue perfusion related to low blood pressure, and hypovolemic is low volume shock. So they could have bled out, they could be dehydrated, whatever, but it's a low volume shock, is being managed in the ICU, which findings indicate improving hemodynamics. So this isn't about treatment, it's about how do you know they're getting better, okay? Urine output 50 mils per hour, heart rate 110, blood pressure 110/70, serum lactate decreasing, central venous pressure 2 millimeters of mercury, capillary refill less than 2 seconds. So if someone, basically what we're looking for is we're looking for answers that show they have good tissue perfusion, okay, good tissue perfusion because they're getting better, improving hemodynamics. Hemodynamics is blood pressure resulting in good tissue perfusion. So which things indicate good blood pressure, good tissue perfusion? Urine output of 50 mils an hour is good tissue perfusion. So greater than 30 mils an hour is good tissue perfusion. Heart rate 110. Remember, heart rate goes up to try to compensate for low blood pressure. So if the heart rate is still up, the body's still compensating. So I don't like that answer. I'm looking for the heart rate to go down, telling me the body no longer has to compensate. Blood pressure is good, 110/70. That's good. That tells me that's pretty straightforward. Serum lactate is decreasing. Remember, lactate is an indicator of anaerobic metabolism. So if the lactate level is decreasing, we're now getting enough oxygen to the tissues, and that's good. Central venous pressure 2 millimeters of mercury. So central venous pressure is the pressure in the veins. As volume goes up, pressure goes up. As volume goes down, pressure goes down. So normal CVP is anywhere from 2 to 6, 2 to 8, somewhere in there. So we're on the low end of normal. So I would actually expect CVP to be going up. Now, here's the problem. I don't know what CVP was, but it couldn't have been, it probably was 2. I mean, you can't get much lower than 2. So it could have been 1. But like, that's not high enough for me to say it's getting better. I would, in fact, if I saw that, I would go, it's still pretty low. I'm giving them volume, right? I'm giving them volume to try to get the CVP up because as volume goes up, CVP goes up. So I don't feel comfortable choosing that. Now, it is the low end of normal for some values. Some labs would say that's the low end of normal, but I just don't feel like just clinical reasoning and common sense says that's not telling me they're getting better. Capillary refill less than 2 seconds. So capillary refill gives an indication of tissue perfusion, right? If you have capillary refill less than 3 seconds, your tissue perfusion is good. So capillary refill less than 2 seconds tells me that they are getting better. So I'm looking basically for the normal or the improving levels here. A client with acute stroke is at risk for DVT. Which measures should the nurse implement? Acute stroke is at risk for DVT. Apply graduated compression stockings, scheduled passive range of motion exercises, administer prophylactic low molecular weight heparin, place pillows under the knees, bed rest per protocol, massage calves to promote circulation. A client with acute stroke is at risk for DVT. So they don't have a DVT. I'm glad I went back and reread that. They don't have a DVT. I want to prevent DVT. So what I'm looking for are interventions that prevent DVT. Okay, so that's what I'm looking for. Prevention of DVT. Apply graduated compression stockings. Yes, that will prevent DVT. Scheduled passive range of motion exercises. Well, moving, active, I'd rather they do active, but they did come in with an acute stroke. So passive range of motion is better than nothing. So I'm moving them around, remember the muscle pump helps move blood, and which will prevent DVT. Administer prophylactic low molecular weight heparin. Yes, that will prevent DVT. Place pillows under the knees. That does not prevent DVT. I'm not saying you can't put pillows under the knees, but that doesn't prevent DVT. In fact, it does more compression of the vessels, and it is more likely to increase risk for DVT. Bed rest per protocol. Bed rest per protocol may be fine for stroke, but it does not prevent DVT. We're looking for answers that prevent DVT. And bed rest does not prevent DVT. Massage calves promote circulation. I already told you we don't massage calves. Like, we don't do that. So the correct answers are A, B, and C. Those are the classic ways to prevent DVT. A client with liver disease has coagulopathy. Which interventions should the nurse include? All right, liver disease has coagulopathy. So that says impaired coagulation. Now, you do have to know that liver disease causes slowed clotting. So coagulopathy means they are at risk to bleed out. They're going to have slowed clotting, which means they're at risk to bleed out. So we're looking for interventions for a patient who is at risk to bleed excessively. Electric razor for shaving, administer vitamin K as ordered, encourage toothbrushing after every meal, use small gauge IV catheters, side rails up ×4, wear hard-soled shoes when walking. So really, these are things that are bleeding precautions. We're looking for bleeding precautions. So is the electric razor for shaving a bleeding precaution? Yes, it is. Administer vitamin K as ordered. Well, vitamin K is the antidote for Coumadin, and with liver disease, they have decreased vitamin K clotting factors. So it's sort of complicated, but with liver disease, they don't absorb the fat soluble vitamins. A, D, E, and K are the fat soluble vitamins. And with liver disease, they don't absorb those. So they have low vitamin K, which means they have increased bleeding risk. So we give vitamin K for that. And so, yes, that would be appropriate as ordered. Encourage toothbrushing after every meal. Well, that's nice for your teeth, but it's not good for bleeding. So if they're already at risk for coagulopathy, I don't think brushing your teeth with a soft toothbrush twice a day would be okay. I might even want to use like something even less aggressive. Use small gauge IV catheters. Yes, because you don't want them to put a big old catheter in there. They might start bleeding around it. Side rails up ×4. That doesn't do anything for coagulopathy. Now you may say, well, it decreases their risk for falling, but it doesn't say they're at risk for falling, and it's considered a restraint. Side rails ×4 is a restraint. If it said side rails ×2, I would have picked it for sure. Side rails ×2 is a good option because it does decrease the risk for falling. And I don't want them to fall if they're at risk for bleeding, right? Because they could get a big old hematoma if they fell on their head or something. But side rails ×4 is a restraint. Wear hard-soled shoes when walking. So why would that be for bleeding risk? Because you don't want to step on something and hurt yourself. So that actually is part of bleeding precautions. So A, B, D, and F are the correct answers. Sorry, I have some in my eye. A client with unstable angina experiences chest pain unrelieved by nitroglycerin. The nurse notes hypotension and diaphoresis. Which action should the nurse take? Unstable angina, chest pain, unrelieved by nitroglycerin. So that's not good. They're also hypotensive and diaphoretic. So that's not good. So it sounds like we need to be pretty aggressive in our actions because they are unstable. This person is unstable. The treatment that I can do didn't work and it caused hypotension. Notify the provider. That sounds like a good, well, I got to read the answers first. Sorry. Notify the provider, give a second nitro, prepare for reperfusion therapy, obtain a 12 lead, check orthostatics, administer IV morphine as ordered. All right. So they're unstable, y'all. This person's unstable. Notify the provider. Yes, absolutely. Give a second nitro dose. No, because they're already hypotensive and nitroglycerin can cause worse hypotension. So I don't want to do that. Prepare for reperfusion therapy. So there's different ways you can reperfuse. You can take them for a cardiac cath and you can balloon them open. You can, if they have a clot, you can do clot busters, but I would want to prepare for reperfusion therapy. They're unstable. They're having chest pain that's unrelieved by my medical treatment that I have available to me. So I think reperfusion is probably what they're going to need. And preparing for reperfusion therapy means mentally preparing for it. It means when it says prepare for something like that, what it means is, this is likely going to be needed. And it makes sense that reperfusion therapy would be needed. Obtain a 12 lead, absolutely. Check orthostatics. All right. They're already hypotensive. Do I really want to check orthostatics? Is that really a priority when they're having chest pain? Well, let's get you up and stand you up and see how your blood pressure does. Let's not. Administer IV morphine is ordered. Morphine is a standard of care treatment for unstable angina or chest pain angina that can't be relieved with nitro. It's a very common treatment. So yeah, I like that one. So I'm going to notify the provider, prepare for reperfusion therapy, get a 12 lead and administer IV morphine as ordered. Okay. Well, I hope that was helpful to you. Good luck on your Nclex. We are primarily an Nclex prep channel. And so that's what we help you prepare to do. And we wish you all the best. Go to clinicreviews.com if you want to know more about the services that we offer. And if you want to hang out here for a minute, I'll have a short video of my two lovely grandsons. Have a great day.
Is that a bridge?
Yeah.
Uh-oh. There's a bridge inside way over there.
Yeah.
The car will drive into the water and it will go under the water.
Yeah.
And we won't see on the road.
Yeah, that'd be scary, wouldn't it?
Yeah.
That's a crazy picture.